we're going to get started. Again, we're certainly going to be able to make it through thyroid. We'll make it through parathyroid. I'm not sure how far we'll get with adrenal, but I'm going to try to capture all that today if I can, which means that I might be going a little bit faster than you like. But remember, we will be repeating all of this in the 121 content area also. I am going to direct you to my Patho Breeze, which is on WebCT. That is where you can find the diagrams that I'm going to be putting on the board. I just have to share it with you this way. It's the only way I ever finally learned it, so I didn't have to read it out of a book, where it finally got into my noodle. And so that's the way I teach it now, and most students say that it works, and they use it as they go through the rest of the program and to study for boards. Okay, otherwise it's a lot of words that don't make sense. So let's try to get started here, and bear with me. It's a lot of content. We're going to move fairly quickly. All right. Some of the endocrine functions that occur in your body, things that are regulated without you thinking about it. Growth and development. Okay, this would be via growth hormone. You'll learn more about that in Block 4. Sexual reproduction and differentiation. Monitoring and modulation of your internal environment. Things like temperature control, blood sugar regulation. The endocrine system has a part in that. And adaptive responses, such as how do you respond to stress? Those are things that happen from endocrine organs. Okay? So what is a hormone and how does it work? A hormone is a chemical message. It's created by something and it has a target. And I've been using that terminology with you a lot this semester, so I could do that right now and say, you know, when the kidney doesn't get enough blood flow, or it senses a lowering of red blood cells, it secretes a hormone. That hormone is called erythropoietin and renin. All right, we could use renin for internal environment, or we could use erythropoietin. And I like erythropoietin because I can go right to the target. What is the target of erythropoietin? Bone marrow. And what response do we expect? Production of red blood cells. When we have enough red blood cells produced, what happens to the secretion of erythropoietin? It stops or goes down. That's negative feedback, all right? The same way as the thermostat works in this room, not always so well as we know. There is a certain temperature that's set in this room. And when the temperature either goes above or below that set temperature, something happens until the temperature returns to the set point, yes? And then those mechanisms stop. The cooler or the heater stops. That's what happens in your body endocrine-wise with most all systems, and we call that negative feedback. There are a few mechanisms that occur in your body by means of positive feedback, and they're related to breastfeeding and childbirth. That is exactly right. And with positive feedback, once the stimulus is started, you get more and more and more hormone until the event is completed, until you have the baby or until you have released the milk. Okay? So, as you can imagine, it's a good thing that that's not the way most of the hormones work in your body, or we'd be a disaster all the time. So, most work by negative feedback, but there are a few that work by positive feedback. This diagram is the one that I'm going to be using when I draw my pictures. I believe it's from your Bruner. You have Bruner, right? I believe it's from your Bruner book. It is the very best diagram I have ever seen that talks about how the brain works with the endocrine system to produce needed levels of hormone, and then things shut off. Okay, so the diagrams that I use on my handwritten notes refer to this diagram that's in your Bruner. I find it very helpful. So for instance, when I'm drawing for you today and I draw diamonds, those diamonds represent the hypothalamus. That's a neurological structure which is like your switchboard. Remember the old telephones where you had an operator that was pulling in and out little cords on a switchboard? And that monitor was listening in on all these different conversations and being aware of things that were going on. Well, that's kind of like how your hypothalamus is. It's your switchboard. It knows what the set points are. It knows where things are supposed to be. And it plugs in or turns off based on monitoring your body, those set point levels. Okay? If something is not where it needs to be, the hypothalamus sends a message down to your pituitary gland, which is considered your master gland, your master endocrine gland. You remember that? When you learned that in anatomy and physiology? Okay, so let's say we don't have enough thyroid hormone. The hypothalamus will be telling the pituitary gland that. And the anterior pituitary then will secrete TSH, thyroid stimulating hormone. Its target is the thyroid gland. And in response to that, it's supposed to secrete T3 or T4. And when that level becomes high enough, what happens in the hypothalamus then? Stuff shuts off. And that's negative feedback. I know this image is not real wonderful, but all the pictures I'm going to draw are based on that, so you can refer to that in your book if you like. All right, so I'm supposed to remind you then that there is a relationship between your neurological system, your hypothalamus, your endocrine system, your pituitary gland, and your immune system. The clearest example of that is when you're under stress and the response of your adrenal gland in releasing cortisol. Okay? We'll go through that when we do the adrenal glands. All right. These are the important key concepts. The first thing we'll do as we talk about these particular glands and hormonal things is we will talk about normal. And then we will talk about situations where it's either hypo, not enough, or hyper, too much. Which side of the board would you like for me to make the hypo side of the board? Because some of you are type A, and the direction in which I write is critically important to you. Which side of the board should be hypo? That's what I figured you'd say. And that would be my choice, but I want to be sure that we are dealing with it the way that makes sense to you. And then when I'm talking about other imbalances that are hyper, I'm going to put them over here, right? Okay. Key concepts, generally speaking. If a patient is hypofunctioning in the endocrine system, we give a drug. Write that down. Generally speaking, if your thyroid gland is hypofunctioning, we give a drug. Generally speaking, in the endocrine system, if something is hyperfunctioning, we cut it out. Or we do something to suppress it. Do you see, though, the key concepts? If something is hypo, we give a drug. If something is hyper, we cut it out. Or we do something to suppress it. Just understanding those two key concepts can help you sift through a lot of the garbage related to endocrine problems. Now, there are several slides which refer to causes of hypo and hyperfunction in the immune system. Do not memorize them. I really don't care if you know it or not. And what you're going to find is that the lists are almost identical. Things that can cause hypofunction, things that can cause hyperfunction. So do you think the state boards will ask you that? No. Probably not, because it's pretty much the same list. Don't memorize it. Be aware autoimmune cancers and infections can cause hypo or hyperfunction. That's all this slide is here for. That's all this slide is there for. The lists are almost identical. Do not memorize them. Okay, pituitary disorders. I don't get to talk about them, and it may not even be on your list. Is it on your list in your notes? Yeah. Well, we're going to skip them because you're going to get that in block 4. If you need my breeze, it's there for you in block 4 to understand the patho. If you were in my 240 class, we would go over it right now. But we don't have time to add it. I apologize. So I'm going to skip through that. There is the diagram, though, if you're very visual, okay? And I'm very visual, so I like to draw stuff. And these are the disorders, and I'm skipping them. They are on the breeze, though, if you want them. And I am going to be starting with thyroid. You will not be tested over growth hormone and its abnormalities, or antidiuretic hormone and its abnormalities. But you have the breeze information, all right? You also have my diagram, but I'm not going to put that up there at this moment because I want to draw it for you. And I want you to draw it with me. And then when you look at it or you try to reprint it, you'll understand. First, remember normal. To learn endocrine issues, start with normal. This represents the hypothalamus. That is your switchboard. That knows the set point for thyroid. Incidentally, what is thyroid? Thyroid is your hormone of regulation. Metabolism. Metabolism. So when you think of thyroid, I want you to think of metabolism level. Now, when you don't have enough thyroid hormone, this is what's supposed to happen. This is what's normal. And I recommend that you write this right down the middle of your page. When you don't have enough, your anterior pituitary, which is this thing right here, will secrete thyroid stimulating hormone. Its target is the thyroid gland. Okay? When thyroid stimulating hormone hits the thyroid gland, you're going to have production of T3 and T4. Those are your thyroid hormones. I do not care that you have any understanding whatsoever of what you have more of, what becomes activated by the other one. I don't care. All I want you to know is release of thyroid stimulating hormone from the anterior pituitary. Its target is the thyroid gland. It makes thyroid hormone. You get that? When we have an adequate amount of thyroid hormone in the bloodstream, by negative feedback, your hypothalamus will note that, and what should happen to the release of the substances? It should stop. It should stop. That is normal. If you understand normal, then you will understand abnormal. And even if you understand only one side of abnormal, that's good, because what's the other side? It's the opposite. All right? So let's start with hypothyroid. There is a special word for hypothyroidism, which means deficient thyroid hormone. Worst case scenario, it's called mixed edema. And that goes along with hypothyroid. Now, since thyroid is your hormone of metabolism, what happens if thyroid hormone goes down? Then metabolism goes down. Thyroid is one of the easiest endocrine disorders to learn, because everything goes down. So if we were to take the vital signs of a patient who has hypothyroidism, what would we find? With the temp, the pulse, the respiratory rate, and the blood pressure. They're all low. If you were to look at the activity level of a patient who has hypothyroidism, what would it be? It's going to be very slow. Very, very slow. If you were to look at fluid movement in this patient, it'll be impaired. They tend to develop edema. Fluid ends up in places that it doesn't belong. If you were to look at the bowel patterns for a patient with hypothyroidism, they would have constipation. Does it make sense to you? Good. Then you'll be able to get all those answers right on the test. All right? Now, when a patient develops hypothyroidism, no matter what, when you look at the lab work, the patient's T3 and T4 will be low. So if I give you a question about lab work, which I will, do you hear that? Then no matter what with hypothyroidism, your T3 and your T4 will be low. But you can have different abnormalities that cause that. You could have a primary abnormality. Primary abnormalities mean it's the gland itself. Or you could have a secondary abnormality, which means that the problem is with the pituitary gland. Now, how can you tell the difference? You can tell the difference if you understand negative feedback. That's how you can tell the difference. If a patient has a primary glandular problem and the thyroid's not responding to what it's being told to do, you will see a low T3 and a low T4. And what will you see happening with TSH? It'll be high. Exactly. That patient has primary hypothyroidism. If you have a secondary problem, remember, you're still going to have a low T3 and a low T4. But if the problem is up here, what else will you see? A low TSH. Now, I prefer that you understand that to analyze it out. But if you don't, you can just tell yourself when it's secondary, they're all the same direction on the arrows. However you need to do it. But no matter what, if it's hypothyroid, what's going to be low? T3 and T4. All right, now let's look at hyperthyroidism. What do you think will be happening to the vital signs in a patient that's hyperthyroid? Yes, they're all elevated. A high temp, a high pulse, a high respiratory rate, and a high blood pressure. There aren't many things that cause a patient to be hypermetabolic across the board like that. There are not too many things. Would we see that in DKA? Well, we might see the temp is up, and we might see the pulse is up because they're volume depleted, but what would happen to the blood pressure? Okay, the only things that come to mind for me are hyperthyroidism and meth. Those make a patient high across the board. There aren't that many things that make a patient hypermetabolic. So if you get that, you want to think hyperthyroidism. The other names would be thyroid storm, or Graves' disease is a form of hyperthyroidism. What happens then to this patient's, like if you were trying to manage the room temperature for them, is this patient going to be hot or cold? They're hot. They are hot to trot, guys. And everything for them, they're going to be running around the room like a chicken with their head cut off. My grandmother, the nurse. I mean, it's good for a work environment, right? I mean, it's good for a nurse. Now, what we want to think about is what happens to the body in a hypermetabolic state. Which organ is going to be most stressed in a hypermetabolic state? The heart. That is correct. And so in a patient with hyperthyroidism, we will have to do things to protect the heart, like give Inderol. Have you heard of that drug? Yes. Give Cardizem. Have you heard of that drug? We give those drugs to protect the heart in cases of hyperthyroidism. Does it make the hyperthyroidism go away? No, but it helps manage the effects of the hyperthyroidism. This patient isn't going to be constipated. What are they going to have? They're going to have diarrhea. Okay, now let's look over here. No matter what, a patient that has hyperthyroidism is going to have an elevated T3 and an elevated T4. Yes? If it is a primary situation, what will you see happening with the TSH? Low. And what about secondary? You're still going to have an elevated T3 and an elevated T4, but you're also going to have an elevated TSH. Why? Because the problem is here. And the treatment could be very different, right? In a state of hyperthyroidism, what are we going to see them do? One choice could be to cut it out or to give a treatment, okay, to suppress the gland. Do we want to do that if the problem is here? You see the difference? So it helps us know where the problem is to give appropriate care. All right, so let's review our slides and make sure I didn't miss anything majorly. Oh, one more job of the thyroid gland, and I don't know if you know that. It'll help with our next discussion. For most patients, their parathyroid glands are inside their thyroid glands. I don't know if you knew that. They're embedded. Did you know that? They're like kidney beans. In some patients, they're embedded, and some people have them like other locations. They draw it always as people having 4, but some people have 7. It just depends. And one other job of the thyroid gland, and it's in relationship probably with the parathyroid, is that it makes calcitonin. Do you know what calcitonin does? Calcitonin helps calcium be deposited into the bone. So you'll see my little diagram. For me, calcitonin is calcibonin. I don't even pronounce it right. It makes calcium go in the bone. So we can give it as a drug to help deposit calcium into bone. In our body, naturally, the thyroid gland makes calcitonin to help deposit calcium into the bone. Calcitonin, calcibonin.
So if they're hypothyroidism, are they hypocalcitonin then?
Maybe, maybe not. It's more associated with the parathyroid disorders that we'll go over in just a moment. Okay? So with hypothyroidism, worst case scenario, the patient will have myxedema. Myxedema is when all the vital signs are so low that the patient can go into a coma. Do you follow? If we have hypothyroidism in infants, they call it cretinism, and it can affect their growth and development. They will not grow to the right height. They will not develop properly. This is a picture of a patient with myxedema. Okay? And what we need to know about this is that these thyroid disorders can come on insidiously. We might not notice them. Case in point, got a call from a family member. Oh, I don't feel so good. I'm so tired. But guess what? I'm used to hearing that all the time. I don't feel so good. I'm tired. I ache all over. I'm gaining weight. I almost weigh as much as you. I'm really not listening then. Unfortunately, what I didn't pick up on, because of my own insecurities and my own annoyance about hearing about those types of things for all these years, was that this family member was starting to develop what? Edema and hypothyroidism. Another family member picked it up. Should I have picked it up as a nurse? Absolutely. So sometimes, because it's a complaint, and we hear complaints all the time, because they sound like the aging process, we miss it. Okay, remember, thyroid problems are much more prevalent in women. So should this be something that gets checked periodically? It should. Okay. All right, diagnosis for hypothyroidism, same as hyperthyroidism. We'll be looking at T3 and T4 levels. If it's a primary problem, we will see an elevation in TSH. How do we treat it? We give a drug. We restore what is not being made. Does that make sense? Hopefully it does. All right. Hyperthyroidism is the other side of the case here. And excessive thyroid hormone release, there are several different names. For your testing, please be aware of thyroid storm. For boards, you need to know Graves' disease. That's a state of hyperthyroidism. This particular picture shows you, number one, an enlarged thyroid gland. You see that? They call that a goiter. And sometimes it looks like they have a big ring around their neck. What you need to know about goiter is that sometimes a goiter is a euthyroid patient, meaning they're not hyper or hypo. All a goiter means is you got a ring around your neck. It just means your thyroid gland's enlarged, and they're going to have to do studies to find out if it's hyper, hypo, or euthyroid. You can't tell anything by looking except that it's a goiter. In this patient, it is hyperthyroid, and you are seeing one of the classic presentations of hyperthyroidism called exophthalmos, meaning that the eyeballs stick out. In some of these patients, they cannot close their eyelids all the way. Their eyeball is protruding so much. The hypertension that goes along with hyperthyroidism causes edema and swelling in the ocular muscles and behind the eyeball, which makes it poke out like that. So that's a manifestation of hyperthyroidism. Do you think we see this in hardly anything else? No, we really don't see this in hardly anything else. So is this one of those key assessment findings? It's a key assessment finding. All right, Now, Graves' disease is an autoimmune issue, and this picture is really nice when we talk about endocrine issues because it shows you someone that comes in with lots of hyperthyroidism going on, and it lets you understand that with many of the endocrine issues, when we correct the hormone imbalances, they can return to a more normal appearance. This is helpful for the patients to know as well.
In eyes, is it common with Graves for them to stay somewhat? My coworker had Graves, and they did with the
Radioactive iodine?
The iodine, and they did too much, but she still has the iodine.
I suppose if there's hypertrophy of those muscles back behind, it could, but in most patients, it will return.
Okay.
And in most of the endocrine disorders, adrenal disorders, thyroid disorders, parathyroid disorders, they will restore their before disease appearance. But you can see that's quite a different look. Okay, so clinical symptoms, adrenergic stimulation, and that means they're hyper. It's like having too much epi, norepi. They're hyper, their heart rate's up, their temp's up, and metabolically they're going crazy. Lots of oxygen consumption. How much food do you think this patient needs to eat? They get to eat a lot of calories. That wouldn't be so bad, would it? That wouldn't be so bad. I don't think I would be minding that as much if I get to eat a lot of calories. But the poor heart might take the toll too. All right, thyroid storm is a situation where if we don't correct for the patient, they can actually not survive. Okay, things we can do if the patient has an overactive thyroid. One thing we can do is cut it out. That's one thing we can do. Another thing was mentioned, like you mentioned, using radioactive iodine. And we're going to talk about that more in the next class. But what you need to know is iodine is necessary for the synthesis of thyroid hormone. It is necessary. Knowing that helps us to use iodine to not only diagnose, but treat thyroid conditions. So if we use a little bit of radioactive iodine, if the patient is hyperthyroid and we're testing them, what's going to happen to all of that iodine? It's going to take up in the gland, and we'll be able to see that it's a hyperthyroid state. Now, if we were going to use that same radioactive iodine concept, knowing that it's hyperthyroid, we can tag it with a lot of radioactivity, I-131. Our intention in giving a hyperthyroid patient I-131 is that it all takes up in the gland and kills part of it. My grandmother had I-131. They gave her too much. It completely burned out her whole gland, and then she was on thyroid medication for the rest of her life. Okay? So, iodine is necessary for synthesis of thyroid hormone. So we can use that fact and that knowledge to use iodine with a little bit or a lot of radioactive charge for testing or for treatment. Do you get it? Okay. And we better protect that heart. Okay. Now we're going to talk about the parathyroids, and that's all we're going to get through today. Here's my diagram. You can download that and copy it if you want to. We're going to draw it now so that you have your own. Again, I will tell you, this is the only way I finally learned it. Before that, parathyroid always went shoo, thyroid always went shoo, adrenal, it all went over my head. It was just too complex. But if you simplify it to what is supposed to happen, what happens if there's not enough or too much, I think you can get it. I think it's worth a try. Specifically thyroid, because that's probably what you're going to get on boards. All right. Now, when we talk about parathyroid, those are those little kidney-shaped type glands that are found in the thyroid. Oh, let me ask you something else. We'll talk about it in the next class. But let's say you do have a thyroidectomy. What's going to be going out with the thyroid gland? Remind me to make sure we talk about that significantly in the next section. The parathyroid glands regulate onto themselves. They do not interface with the brain. So if we lose the parathyroid glands, we lose calcium regulation. So when you think of parathyroid, the whole connection is calcium. So when we have a low calcium level, in response to a low calcium level, the parathyroid glands secrete. Can you even see that? Do I need to move it up? I need to move it up, don't I? It's too low. In response to what? In response to a low calcium level, the parathyroid glands secrete parathyroid hormone, or PTH, or it's also called parathormone. It depends on which book you read. Parathyroid hormone or parathormone are the same thing. Okay? Parathormone's target, its target is bones, teeth, and your gut. That's supposed to be like your stomach, sort of, kind of. But that's why I have to label it, because people are like, I don't get it. All right, so parathyroid hormone is going to do everything it can to have increased absorption of calcium, or it's going to steal it. And once the calcium level goes up, then what happens to this? Right, the glands will know, and the production of parathyroid hormone should go down. That's normal calcium regulation in your body. So let me ask you a question. There's another piece related to absorption of calcium from the gut. You just learned about it. What is it? You have to have activated vitamin D. And what organ activates vitamin D? Kidneys. The kidneys. So in a patient that has renal failure, are they going to absorb calcium right? No. And they're going to develop a state of hyperparathyroidism because of their disease, which means you're going to be releasing a lot of parathyroid hormone. Where will the calcium come from? Where does that patient get their calcium from? Out of their bones and their teeth. So a renal failure patient is going to have what kinds of bones and teeth? Weak and wholly osteoporotic bones and cavity-filled teeth. Okay, so parathyroid's really easy to learn. In hypoparathyroidism, they have a low amount of parathyroid hormone. When you look at their labs, you're going to see a low serum calcium. Why is it easy? Because the arrows go in the same direction. Do you follow? If the patient doesn't have enough calcium, what am I going to do? I'm going to give them calcium. Give them what they're missing. It's as simple as that. We'll talk more about some of the assessment parameters that we see with hypocalcemia. One of them is the big T. What do we see if a patient has hypocalcemia? We see tetany. We'll talk about the assessment tests for that. Okay? Now, on the other side, if a patient has hyperparathyroidism, they're secreting too much parathyroid hormone. And what will happen with the calcium level? It will go up. Now, this is tricky when you're thinking about it, because the example I used for you was another disease state, wasn't it? And when you look at a patient with renal failure, they're going to be making lots and lots of parathyroid hormone, but their calcium level will still be low. Not the best example, but we see it clinically all the time, so I brought it up. Let's say that the patient has a hyperparathyroid adenoma. I took care of a patient who had this recently. Don't see that very often. This patient came in the gate with an elevated calcium, which caused him to get pancreatitis. That's what he was there for. Actually, I had him Sunday. Okay? So he had an elevated calcium because of a parathyroid adenoma, right? That was his disease process, and his serum calcium level was really high. He's at risk for things such as pancreatitis, but also the biggest thing that usually happens, kidney stones. The thing about calcium is that it does not dissolve well in the serum. If we have high levels of calcium, it tends to form rocks in the bloodstream. And when we have rocks in the bloodstream, where do they usually end up lodging? In the kidneys. And so we'll really worry about a patient with hyperparathyroidism that they're going to develop kidney stones, or that their kidneys will get jammed up with calcium and they'll go into acute renal failure. That's one of our big concerns with that. Now, this patient with hyperparathyroidism, one choice for him would be to cut it out. They could do a hyperparathyroidectomy. If they wanted to, that would be one choice. They could do radiation over the area. There are several different choices. Acute management of hypercalcemia, though, has to do with giving them something that's already produced by the thyroid gland itself. What do you think we'll do to try to get that calcium? We'll give calcitonin. That's one of the management strategies for a patient in hyperparathyroidism. And how does that help?
Helps the bones to absorb the calcium.
Right. It will take that calcium into the bones. Calcitonin, calca, bone in. It helps deposit the calcium into the bones. Very, very useful. Other things that you're going to see, and again we'll talk about them in the other class, this patient will be given a lot of IV fluids. What is the purpose for the IV fluids? We want to flush out those calcium rocks. We are seeking to protect the kidneys. The other things that we will do is give diuretics. So plenty of fluid and diuretics to help protect our kidneys.